This episode is sponsored by our global research partners. Want to contribute to the advancement of medicine? Make some easy money while sharing your thoughts with market research surveys. Learn more and sign up using the special TFOC link on our website and in the description box below.
Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy!
Welcome to another episode of The Fellow on Call, the Hemong podcast. We're coming at you from Rilo University Medical Center. I'm Roduk.
I'm Vivek.
And I'm Dan.
And in today's episode, we are talking all about acute complications of sickle cell disease and how we manage these.
Excited to get into this one. You might hear Dan and I argue whether hyperhemolytic crisis is real or not. It's a good discussion to have. It's real.
Excited.
Yeah, I will see. It's a good thing to talk about acute chest syndrome, hyperhemolytic crisis, pain crises, all of these really important things that we see in the inpatient setting.
Yeah, I think that this is something that a lot of folks might see on the internal medicine service or on their ER rotations and just have this visceral reaction like, oh gosh, this is going to, like, what do I do? This is going to be bad. It doesn't have to be this way. There are really well-established ways of handling an acute crisis, and I'm excited to go through them today.
Let's roll right into it then. Guys, many months ago, we had talked about what our favorite brunch is. And on the other end of the spectrum, what are our thoughts on ice cream? That's kind of what's all on my mind right now. It's like 8:15 at the time that we're recording. I'm craving something a little bit sweet. What's your ice cream of choice?
Yeah, I'm all about Jenny's ice cream. You know, they've always got a different flavor, different things going on. But right now they have this double dough flavor. Absolutely delicious. So to go Jenny's ice cream double dough flavor. That's what I want right now, at least.
Yeah, I gotta be pretty similar to you there. I think Ben & Jerry's half baked. I'm not sure ice cream has gotten better since then. Cookie dough, brownie batter. It's any other flavor. I'm comparing it to that, and they all come up wanting.
I will say the only exception to my usual that I will make is when I'm at Jenny's, their coffee ice cream is fantastic and one of my favorite things to get. I'll let you guess what my normal ice cream flavor of choice is, though.
Is it pistachio?
It's not pistachio.
That was just an Indian thing. I don't know if that,
It's actually
Is it vanilla chocolate chip?
It's just vanilla. Actually, I just love just plain vanilla ice cream.
All right, Rhoda.
It's an incredibly complex flavor. I'll give it to you. I'll give it to you there.
Most people aren't surprised when they learn that it's vanilla. So, but I'm glad that you guys are a little bit more adventurous than I am. Like I said, I step out of my comfort zone only for the coffee ice cream at Jenny's, though. And with that in mind, that is a poor segue. But with that in mind, let's go ahead and talk a little bit about what we're here to talk about today, which is acute complications of sickle cell disease. And so we have a case once again to kick off this episode, and I'm just going to use that to get our conversation started. Y'all ready?
Yeah, let's do it.
So we have a 24-year-old female with a history of morbid obesity, pulmonary hypertension, and hemoglobin SS disease who is presenting with pain in her back and bilateral lower extremities that is typical for her prior vaso-occlusive crises, although this time is more severe than usual. These symptoms started after she was up all night taking care of her nephew, who is 2 years old and has had the flu. She has been unable to control her pain with her home regimen and presents to Rouleau's ER for evaluation. Her vital signs upon presentation are notable for tachycardia with a heart rate of 104 beats per minute and a blood pressure of 145/90, but she's afebrile and she's sitting in the high 90s on pulse oximetry. So when a patient presents like this in the emergency room, Vivek, what is your approach to managing this presentation?
Yeah, this is one of the most common things that we see in hematology are these patients who are coming in for their acute pain crisis. And some important things to do are a CBC with differential, a type-in screen with an extended phenotype if they're new to the system. Remember that these patients have chronic transfusions and have lots of alloantibodies that are produced. So it can be challenging to find a compatible unit of blood. And that's why, if they haven't had this yet, an extended phenotype testing for the blood bank is very, very useful. a hemoglobin S percentage is nearly a must. This is not the same thing as a sickle dex, which is a yes/no on a sickle hemoglobin used in newborn screening, but actually the percentage of hemoglobin S. And you get this as a baseline, particularly if you're worried if the patient might have something like acute chest. And lastly, you get a CMP, so just your basic labs. The next thing I do is really to look for a pain plan. So we're fortunate that we have pain plans in the chart for all of our patients, but that may not be the case, right? These patients may be seen at a different clinic and you don't have access to those records. But if they do, it's important to look for that if it's in the system. Typically, when they're presenting for this type of pain, you can try an oral regimen, and emergency department doctors are pretty good about trying that. And often that doesn't work. And these patients will need something like a PCA for their pain, using opiates to really help control their pain with basal rates and demand dosing. And that's a very difficult thing to do and a very nuanced question on how to manage. And you'll hear a lot of different opinions, but it's important to remember that sickle cell disease patients deal with chronic, lifelong pain and have a very high pain tolerance. So, Dan, you're seeing a patient like this. How do you approach starting their PCA if they need it? You've tried the oral regimen. Now they need something like a PCA. How are you exactly going to do that?
I'm so glad you touched on those points. You're absolutely right. Like a patient with sickle cell disease has a very high pain tolerance, and many of them tell me that they try more than anything to avoid coming into the hospital because so many of them have faced these really difficult experiences, being accused of seeking pain medication or being questioned on their diagnosis if it's even real. And so if they've made the decision to come seek care, you have to know their pain must be out of control and needs to be dealt with really aggressively. And so, like you said, start with the ED pain plan. But if that's not there, you have to kind of use your own best guess as to what PCA settings are going to get their pain under control. So it's always good to start with their home regimen, what their past 24 hours of pain control medication usage has looked like, and then use that to try and derive a reasonable starting regimen. If they're on pretty high doses, if they're on a lot of these oral morphine equivalents worth of pain medication, then you can consider starting a PCA with a basal infusion, a continuous infusion. But if sort of in your calculations, that continuous infusion works out to like less than 0.1 per hour of hydromorphone, I usually avoid that altogether and go with demand only. And so the other important thing to keep in mind when you're starting a PCA, you need to kind of get them up to speed quickly with a bolus dose before as sort of a loading dose to give as you're starting the PCA, especially if it's demand only, those 0.2, 0.5 of hydromorphone every 10 to 20 minutes, whatever your settings are, that it's going to take a while to get people up to speed if that's all they have. So getting them off to a good start with a loading dose, getting them on a reasonable regimen based on their home dosing is the way that I go about it. And in our show notes, we'll have like a little example of how we derive based on home opioid use, how we could derive with actual numbers, some settings. But I always, whenever I'm doing this, I like to enlist the help of an app to help with conversion between different opioids. And we'll have a link to that in our show notes as well. The one I use is just called Opioids. It's available in the App Store.
Yeah, I think that's so important. And check out our website to really look at this patient example that Dan laid out for us because it's very, very helpful. So now let's say we've got our patient on the PCA. We have getting improved pain control. We still have some work to do. But beyond pain control, Ronak, what are some other things that we really need to be doing for these patients when they come in for this vaso-occlusive crisis?
Before we get to that, though, I do want to make one comment as a follow-up to the pain regimen that we were talking about. It is super important for us to reassess patients after they are started on a pain regimen. And this is because, number one, we need to know whether or not that medication is actually working. Do we need to adjust that PCA any further? And also, are patients having side effects like itching or nausea related to the opiates that we're giving them? So it's inappropriate to just start the PCA and walk away and check on them, the next morning. Frequent reassessments are an important component of their pain plan and their pain regimen. So with that in mind, in addition to just pain control, there are other things that we need to pay attention to. For instance, we talked about how being hypoxic predisposes their cells to become sickled, and that further exacerbates this whole process. So making sure that we try to maintain high oxygen saturations above 95%, for instance, is really, really important. The other thing that we want to do is maintain good hydration with IV fluids as tolerated based on their volume status. So again, you don't want to just put every single person on IV fluids, but especially if they have signs of volume overload already or if they have underlying pulmonary hypertension. But, that being said, if there are signs of dehydration or there's signs of infection and you think that the addition of fluids is warranted, then go ahead and add those as well. And then you also want to consider adjunctive regimens like Tylenol or ketorolac if kidney function permits. Heating pads are also fantastic to help manage pain at the source of where it may be happening. And also things like muscle relaxers are also can be helpful in this setting. In addition, this is often something that people always forget. So when you go to the bedside to reevaluate them, make sure there's an incentive spirometer there. It seems really fundamental and super basic, but having an incentive spirometer and encouraging your patient to frequently use the incentive spirometer is actually a great way to help avoid atelectasis, which can predispose patients to acute chest.
Yeah, I think that's all really critically important. We need to be reassessing these patients throughout the day, making adjustments to control their pain, and also doing the adjunctive measures that Ronak had talked about. It's not one of these things that we just say, hey, start antibiotics if we're somewhat concerned for pneumonia, for example, and then just leave the patient be, right? We have to reassess these patients. And it's really, really important to prevent this acute chest situation. So for our patient, her pain is under good control, and she ends up losing IV access overnight. The nursing team is unable to restore it without the help of the PIC team, who are not available overnight. Anesthesia was paged, but is also unavailable, as all the providers are in the OR dealing with a multiple causality accident involving a city bus. So she receives IM hydromorphone, but this is not effective. IV access is restored with the PIC team around 6 a.m., but you're paged at 7 a.m. that the patient's oxygen saturation has dropped. Her vitals are now as follows. Pulse 110. She's febrile with a temperature of 39 degrees Celsius. Blood pressure 130/72. And she's now satting 88% on 4 liters by nasal cannula. You ordered a chest x-ray that showed diffuse bilateral opacities, which were new compared to a remission chest x-ray. And that just really tells you how important it is to assess for something like acute chest in these patients. So now we have this patient, newly hypoxic, didn't have good pain control overnight. What's going through your mind right now?
Yeah, as you referenced, this is super concerning, and specifically concerning for acute chest syndrome. The first thing you should do before you even start trying to figure out if you're worried about this, if it's mild or moderate acute chest or severe, just go ahead and get the hemoglobin S level sent and checked, because if you do need to proceed with definitive management of this with an exchange transfusion, you'll need that information. So don't delay in sending that off to the lab. Acute chest syndrome it's sort of a very severe potential complication of these pain crises. It can be set off by other things, but there are sort of specific diagnostic criteria that define this syndrome. One is a new pulmonary opacity involving one or more complete lung segments. And so she definitely meets that criterion. And the other is you have to have one of any of the following criteria. A temperature greater than 38.5 degrees Celsius, and about 64% of adults with acute chest have this. It's definitely one of those common criteria. Or a 3% or greater decrease from baseline oxygen saturation, or tachypnea, or visibly effortful respiration, so things like retractions, nasal flaring, accessory muscle use, or cough, or wheezing, or rales on exam, so crackles in the lungs, or chest pain, which is probably the most common other criterion. About 84% of patients will present with that. And as I mentioned, there's a broad spectrum of presentations for acute chest syndrome. This can range from mild acute chest, which is folks coming in with a little bit of chest pain, maybe a new mild pulmonary infiltrate on their imaging, and maybe a viral infection like a mild viral pneumonia, all the way up to severe disease, which progresses really rapidly and is immediately life-threatening. Most commonly, the acute chest syndrome that we encounter in the ED is the mild type. It's somebody with a fever and a few faint opacities with a low normal oxygen saturation on room air. In these patients, if they don't have a history of severe acute chest that's required exchange transfusion in the past, it's very reasonable to start with 1 to 2 units of simple transfusion, simple red cell transfusion, giving some nasal cannula oxygen to help maintain that oxygen saturation. Remember, we're trying to break the cycle of deoxygenation and polymerization. And then antibiotic coverage for community-acquired pneumonia. Oftentimes, that'll be enough to reverse the underlying pathophysiology and improve oxygenation. Be sure to get a second hemoglobin S level after they're transfused, because if they do start to worsen and you need to proceed with exchange, you'll want to have that new baseline. So if you're even a little bit worried that the oxygen saturation is too low or developed quickly, get the blood bank on the phone right away, start making preparations for that next step. Let's take a moment to learn more about the sponsor for today's episode. Imagine there was a way you could use your expertise as a healthcare professional to contribute to medicine, to improve the patient experience, and help impact the development of new drugs and devices, all while making some extra money.
We have the solution. Market research surveys through our partners, M3 Global Research, All Global Circle, and M Panels. Through their easily accessible and secure platforms, you can complete market surveys on your own time. It's the perfect way to make some extra money while making a difference. It's so easy, and we couldn't recommend it more.
To learn more and to sign up, use the special TFOC link on our website, thefellowoncall.com, and in the description box below.
Yeah, I think that's all really, really important, that we are tracking the hemoglobin S level when we're worried if we need an exchange transfusion. And just for our listeners to know, what is the difference here? You hear simple transfusion, you hear exchange transfusion. Simple transfusion just means I'm transfusing a unit of blood. That's restoring normal hemoglobin, diluting down that hemoglobin S percentage. An exchange transfusion means first I'm going to draw out some of the patient's blood and I'm going to replace it through a circuit, almost like a dialysis circuit, with blood, with lots of normal red blood cells. So it's a big transfusion medicine thing where you're literally exchanging their blood with lots of blood transfusions that you can't do feasibly outside the body, right? Because if you keep on giving blood to a patient, you would volume overload them, right? You get taco, you get trolley, you get all those issues with transfusions. Whereas with this exchange transfusion, you're just exchanging out the sickle blood and replacing normal blood there. So it's a bigger procedure. It needs a large line. You know, these patients sometimes need to go to the ICU or they need to go to some form of a dialysis unit to get this done. So it's a big deal. So we have this patient now. Ronak, is this the patient who has the severe type, or is this the patient who you're just going to give a couple simple transfusions to?
You know, from the initial presentation, we know that this patient has a history of acute chest in the past. Furthermore, you know, even though we don't have a good litmus test, just by listening to what her presentation is, looking at those vitals, it's very evident that she doesn't sound very mild. In fact, she sounds pretty severe. So, you know, in her case, we're starting to think that maybe her pain crisis worsened overnight because of the complications of not having IV access and not getting adequate pain control, which then rapidly caused the development of acute chest. So severe acute chest should be managed with that emergent exchange transfusion that we just talked about. So, you know, the question always comes up, what patients should we actually be thinking about exchange transfusions for? And so the patients that we should be thinking about that for include patients that have a history of severe acute chest that has required exchange in the past, the acute onset of chest X-ray findings that are diffuse in nature, patients with an oxygenation status that continues to worsen despite a simple transfusion, patients that have hypoxemia that is particularly severe, for instance, less than 85%. Or evidence of other organ systems being involved. The most severe form of acute chest progresses very quickly and usually involves at least one other organ system. Many times, these patients often have multi-organ failure, and so we think that this may be associated with declining platelet counts at the time of presentation. Other indications to consider patients for an inpatient emergent exchange transfusion are patients with stroke or a suspected stroke, again, patients with this multi-organ failure, and we may also offer inpatient exchange transfusions if a patient on chronic exchange transfusions is admitted for another reason and is expected to be admitted beyond the time that they'd be getting their routine exchange in the outpatient setting. This is more of a case-by-case basis. We'll discuss this in a future episode, but that is one other indication. But essentially, for the purposes of this patient, you know, her prior history of acute chest requiring exchange, her hypoxia that we're seeing based on her oxygen requirements, you know, her pain episodes, these new chest X-ray findings, it sounds like she needs herself an exchange.
Yeah, and I think that was a really good recap. And I want to highlight something. When we talked about what we call an uncomplicated veno-occlusive pain crisis, we didn't mention transfusions, right? We're not saying transfuse the patient and they're going to feel better. We actually know that's not true. And it increases the risk of alloantibody formation, right? It makes it harder to actually get compatible units of blood if they develop a severe complication like a stroke or an acute chest syndrome. In these situations where you have this hypoxia, concern for acute chest syndrome, for this patient in particular, there was some time actually getting everything set up. So we ended up giving her a couple of units of simple transfusions, and that is a way that you can help start to temporize these patients before you can get the exchange set up. It's important to know for uncomplicated, non-acute chest, non-strokes, when to transfuse those patients if they're symptomatic. If they're at their baseline hemoglobin and they don't have symptoms, then you don't need to transfuse those patients. But if they're below their baseline hemoglobin or have symptoms, then it's reasonable. And the symptoms what we're talking about are things like dyspnea, severe fatigue, things that would be associated with anemia.
I'm also really glad that you mentioned that her apparent hypoxemia and these infiltrates developed in the context of her pain getting worse overnight. And it's hard to think, okay, well, how's the connection between her pain getting worse and her having this acute chest? It's not just that the pain represents worsening vasoocclusion, although it does, but there's this severe type of acute chest is often caused by infarcts of the bone marrow, often related to worsening pain crisis and worsening vasoocclusion, that then causes this fat microemboli in the chest. And we think that generally causes the most severe form of acute chest that can progress to multi-organ failure. And, in our case, the patient was transferred to the ICU for some high flow oxygen, and we contacted the blood bank for emergent exchange transfusion, and we get everything going. Unfortunately, the patient does have to be intubated prior to us being able to start the exchange transfusion. But after exchange, within hours, we see a dramatic improvement in her respiratory mechanics, and she was able to be extubated after passing her spontaneous breathing trial the next morning. And so she's back to 4 liters by nasal cannula. And I think that really demonstrates just how quickly acute chest syndrome can progress. After about 5 more days in the hospital, we were able to discharge her home. And she was, in good spirits, without any recurrent symptoms when we followed her up in Sickle Cell Clinic the week after her discharge. But 2 weeks after her acute chest episode, she did call into the clinic, now reporting severe back pain, abdominal pain, dark urine, some fevers, subjective fevers. And so we said, go straight to the emergency room, get checked out. And there, a urine dipstick was positive for blood, and the urine sort of a deep reddish brown color. And our initial labs show that her hemoglobin has dropped to 5 grams per deciliter. It was 8.3 when we saw her in clinic just that week before. So what's going on here? What do you think is happening?
So there's a couple of things that I'm thinking of as to what's going on with this patient. So to frame the situation again, this is a patient with severe anemia on the background of her chronic anemia from her sickle cell disease. And she has signs of hemolysis, right? She's got this dark urine, back pain, fever. This reminds me of brisk hemolysis, that with having this hemoglobinuria and the toxicity that can have in the renal tubules themselves and in the ureters and having this pain. So this patient did receive a large volume of donor red cells that we talked about, right? The exchange transfusion, we were exchanging out the sickle cell blood for normal blood. And I'm concerned that this could be a delayed hemolytic transfusion reaction. And Dan, you think about this whole hyperhemolytic thing. I think about it as a delayed hemolytic transfusion reaction for a lot of these patients, and very controversial. It seems to be extremely rare that a patient has hyperhemolytic crisis. And the idea is that you have bystander hemolysis, that maybe you get a unit of blood for whatever reason, you get some hemolysis of that unit, and then that triggers this cascade where you're just hemolyzing the rest of your blood. You have some bystander hemolysis that's happening due to this hyperactivated immune system. And, in this case, the findings of brisk hemolysis, like it has an alternative explanation here, like the delayed hemolytic transfusion reaction, then I don't know if this is a hyperhemolytic crisis, but regardless of what you think about it, there are certainly times when we see patients with sickle cell disease in the midst of an episode of brisk hemolysis that we have to manage. And Dan, how do you manage these patients?
Yeah. And, when we say brisk hemolysis, we're talking like brisk, like clear drop in hemoglobin that you can see over a very short interval of time, that back pain that you get probably from esophageal spasm and diffuse smooth muscle dysfunction from all the nitric oxide scavenging, dark urine, hemoglobinuria, that sort of thing. When you see that, I'm generally thinking, okay, we got to support this person's oxygen delivery with transfusions. And we have to be, very careful about repeating their type and screen, sending that transfusion reaction workup to identify if there is a new antibody, and making sure that we're trying our best to match the blood to all their minor antigens, because DHTRs, delayed hemolytic transfusion reactions, are related, we think, to antibodies against the minor red cell antigens. And in addition to that, in really severe presentations, you can offer IVIG and steroids to try and just interrupt some of that immune mechanism that might be contributing to the brisk hemolysis. I've only had to do that once, and eventually their hemolysis calmed down. Who knows if it was related to the intervention that I took with the IVIG and steroids, but it's something that hopefully you don't have to reach for very often. But remember, this patient is also young enough that she may have some residual splenic function. Typically, the spleen is non-functional by adulthood due to sort of chronic infarction throughout early life. But in children and young adults that do have some residual function, especially those with other genotypes like this hemoglobin SC variant, patients can develop what's called a splenic sequestration crisis, which is a sort of interesting thing that can happen. We'll talk a little bit more about it if that's what this looks like. But let's get some tests. What sort of labs have been coming back during her workup?
So her urine culture ultimately grew fluoroquinolone-resistant E. coli, and the patient was started on ceftriaxone. On exam, the patient does have a firm, tender mass palpable in her left abdomen and extending halfway down to her pelvis and across to her umbilicus. Reviewing old imaging, there is no clear documentation of baseline spleen size, with only some of the spleen being seen on prior CTAs of the chest, but the spleen was of relatively normal appearance on those limited assessments. So as this pictures continues to evolve, the whole idea that I don't believe in hyperhemolytic crisis, but Dan does, we're going to table that conversation for another day, but know how to manage the brisk hemolysis case. We have a patient here, though, who's got this seemingly massive splenomegaly. So how does this new information impact your differential diagnosis?
We definitely need to start thinking about something called splenic sequestration, especially now that we have an explanation for, some of these other manifestations. She may actually have acute cystitis on top of the fact that she also has this other complication. So splenic sequestration is characterized by a constellation of findings, namely an acute drop in hemoglobin from their baseline of at least 2 grams per deciliter. We have to have splenic enlargement on exam, and the spleen is often going to be firm and painful. You're also going to see a drop in their platelet counts as well. And remember, the spleen loves to soak up platelets. And so these platelets, unfortunately, are just innocent bystanders as the spleen is continuing to grow in size. And we may also see reticulocytosis as the body tries to compensate for this acute anemia. So splenic sequestration is actually a very scary situation. Patients can develop hypovolemic shock, and they're basically bleeding to death into their own spleen. I actually had a patient with this in residency, and it was wild to see this, especially in the ICU. It requires a delicate balance between supporting both their hemodynamics and their perfusion, but also being judicious with transfusions. And when the crisis resolves, the patients will usually auto-transfuse all of that sequestered red blood cells into circulation, and then you can run into those issues with hyperviscosity. So you can see just how complicated this all is. In order to manage this, we want to start by supporting their hemodynamics with IV fluids. And if they have symptomatic anemia after that, we can carefully transfuse these patients, generally giving about half of what you might normally give them based on the degree of anemia. So for instance, you might want to start with 1 unit of blood and see if that's enough before you start giving any more. If a patient's hemoglobin starts to rise above 11, you should consider therapeutic phlebotomy with IV fluid replacement to avoid that hyperviscosity complication, which can then precipitate stroke and cardiopulmonary problems, which we've talked about in this episode and prior ones. Certainly something that's not going to happen maybe in this moment in time for someone actually going through this, but considering an elective splenectomy may prevent this from happening again in the future, especially in patients that have residual splenic function like we suspect this patient has. A similar thing can also happen in the liver as well, and here we call this acute hepatic sequestration, and the precautions about hyperviscosity are essentially the same. Fortunately, these episodes tend to be less problematic and have less hemodynamic compromise, Nonetheless, though, they are quite worrisome. And once again, you want to think about, trying to do this delicate balance of resuscitating them with adequate fluids, trying to be judicious with the use of transfusions, but also being cognizant of the fact that they may also have auto transfusion after their acute crisis is recovered.
So I think today we talked about a lot of things, and I just want to wrap it up with a few points that Dan the Man laid out for us. So the first thing is, for an uncomplicated vaso-occlusive pain crisis, one of the most important things is don't just start with a transfusion. A blood transfusion doesn't necessarily make the pain better. We want to manage their pain aggressively and check in frequently on these patients to make sure that we're striking a balance between pain control and side effects like oversedation, itching, and nausea. You also want to rule out precipitants like hypovolemia or dehydration, things like infection. All of those things are important things that we're ruling out as we're seeing those patients. Next, we talked about acute chest. And remember, this is a true hematologic emergency, but it comes in a spectrum of severity that has to be managed in different ways. We have patients who they may present to the ER with chest pain and be on 2 liters of oxygen with some infiltrates, and maybe a couple of simple transfusions will resolve the issue and the patient will get better. That happens sometimes. And then we have the flip side, the patient on 4 liters, 5 liters doesn't look very well, diffuse infiltrates. It almost looks like an ARDS developing picture. And that is the type of patient that will need what we call an exchange transfusion. Exchange out their sickle blood with normal red blood cells. While you're waiting for all that to get set up, a simple transfusion is always a very reasonable thing. And remember, if the hemoglobin is very low, they started with a baseline hemoglobin of 5 or 6, that's not going to work very well for exchange transfusion. So you go ahead and give them a couple of units of simple transfusion because you have to take some blood out before you exchange the blood back in. Next, we talked about other indications for inpatient emergent exchange transfusions like acute stroke and multi-organ failure. And then lastly, remember, if the patient comes in with acute onset anemia, you should always be thinking of something like a parvovirus, which we didn't really talk about this much with aplastic crisis, but also things like delayed hemolytic transfusion reaction, hyperhemolytic crisis that Dan believes in, that I don't believe in, and splenic or hepatic sequestration.
A lot of really important content that we covered today. And Vivek, thanks for bringing all of that home for us. I think that really was a great recap of what we discussed today. Guys, I think, really I was reminded of a lot of important concepts in our discussion today. Definitely going to be helpful for the next time I am soon to be responsible for patients in the inpatient setting that may present like this. I think these were a lot of really good reminders, both for myself and hopefully for our listeners too. So let's stop here, and I'm excited to continue this conversation in our next episode where we talk about some of the chronic complications of sickle cell disease and also, how we manage these patients with different pharmacologic agents in the outpatient setting to hopefully prevent them from coming into the hospital. But until then, we'll see you all later.
See you later.
Peace.